Good evening, everyone. Welcome to the 37th lecture of online PSI lecture series by Education Committee of Physiological Society of India. Before we start today's session, I would like to thank everyone for their support in our recently concluded Physiological Society of India's Foundation Week celebration. Today, we are going to talk about uh, pulmonary circulation. I think. Yes. The pulmonary circulation, its functional anatomy, hemodynamic peculiarities, characteristics and peculiarities, as well as regulatory mechanisms of pulmonary circulation in during health and disease. Before I start, I'd like to give this disclaimer that the information presented here has been collected from various sources and is intended solely for understanding the subject matter. The illustrations are representative of concepts and have primarily been generated using commercial AI tools such as Google Gemini and Microsoft Copilot. These illustrations should not be regarded as actual images or photographs. The information provided should be verified by qualified professionals before being applied in real life situations. Coming to the topic of today's session, it is pulmonary circulation. We have already last, say, uh, around 10 lectures we have conducted on behalf of PSI. We have taken that sessions on cardiovascular system. And last session, 36th lecture was a uh, recapitulation of these sessions. And then today we are moving towards the respiratory system. And in my view, the best way to move to the respiratory system is through the pulmonary circulation. From cardiovascular system, we are now applying the cardiovascular concepts, cardiovascular learnings, what we have already learned during our lectures, cardiovascular lectures. We will move towards the respiratory system. On the way we are discussing the pulmonary circulation, it has some peculiarities. So the outline of today's session, it includes blood supply to lungs, bronchial blood vessels, then pressure, volume and flow, pulmonary reservoir, regional pulmonary blood flow, where we will discuss the zones and pulmonary capillary dynamics. And finally, we will discuss the regulations of pulmonary blood flow. The pulmonary circulation is unique. Broadly, the overall circulation is divided into two major parts. One is systemic circulation and pulmonary circulation. And throughout this session, we will be referring to the systemic and pulmonary circulation many a time. And most of the time, we will be discussing the peculiarities or characteristics or salient features of the pulmonary circulation in comparison or in contrast or in matching with the systemic circulation. So we are considering that you have already learned, you have a good concept about the systemic circulation, and if it is compared and contrasted with the systemic circulation, then the understanding will be easier. Before we go into pulmonary circulation, the functional anatomies, we should know what are the functions of pulmonary circulation. Obviously, the major function of the pulmonary circulation is the respiratory function, where oxygenation of the blood is important. As all of us we know, the RBCs, hemoglobin, and the transport of gases, that is by the systemic circulation. However, to carry the oxygen from the environment to the tissues, to the cells, we need a medium, an exchange organ where the gases can be exchanged with the environment, and lungs is that. So what we are getting from the systemic circulation, that is deoxygenated blood, where the hemoglobins are already used their oxygen as much as they can do, and then again it is being refilled, recharged with the oxygen at the pulmonary, at the lungs level. So respiratory function of pulmonary circulation is the oxygenation of the deoxygenated blood what is coming from the systemic circulation. So even though sometimes we say the systemic circulation is providing oxygen to the tissues, it depends on the pulmonary circulation for the source of oxygen. Other functions, there are some other functions which include metabolic functions, like as during the blood pressure regulation, we have mentioned the angiotensin converting enzyme ACE, and you know many ACE inhibitors are being used in the blood pressure regulations, blood pressure control. Then the removal of bradykinin, endothelin, and the 5-hydroxytryptamine, that is serotonin. And because it's a, we will discuss later that how it can be used. It has the special functional characteristics, functional anatomical characteristics. Because of that, it can filter the emboli without damaging much of the tissue oxygenation process. So it is something like absorbing the harm from the systemic circulation and keeping it within itself, so that the other part of the systemic circulation, the vital organs, can be spared. The blood flow through the lungs. It is a pulmonary vascular bed, as we know, and it resembles the systemic circulation. As already we have learned that the deoxygenated blood, it comes back to the right atrium, and from the right atrium it goes to the right ventricle. From right ventricle, the whole blood is being pumped to the pulmonary circulation, to the lungs, where the lungs is getting oxygenated. Lungs get oxygenated, and it come back to the left atrium and left ventricle, so that it can be given into the systemic circulation. So the whole blood of systemic circulation is coming to the heart through the superior and inferior vena cava into the right atrium, and from there to right ventricle. So this is parallel circulation, or parallel to the systemic circulation, to get the deoxygenated blood oxygenated, so same blood can be recirculated. Overall, the thickness of the large vessels are relatively less in pulmonary vascular bed in comparison to the systemic circulation. 30% of the uh, systemic circulation, like if we think of the this aorta and the pulmonary trunk, if we compare these two, this is corresponding. If the 30% thickness only seen in the pulmonary. What is seen here, like if we consider the 100%, the thickness at the aorta as 100%, only 30% is there in the pulmonary trunk. Relatively little muscle in the wall of small vessels, where in systemic circulation, the this systemic circulation, the small vessels, they are the major source of the resistance. In case of pulmonary system, these small vessels, they are having relatively less muscle on the wall of the small vessels. Capillaries are short, wide, parallel, very much parallel, not exactly only parallel capillaries, but very much parallel to each other. And there are multiple anastomosis. So this is functionally the concepts. These concepts will help us to understand the pulmonary circulation better. If we go into the functional anatomy, first it is starting with the main pulmonary artery. Pulmonary trunk is divided into pulmonary artery, then branches of pulmonary arteries with the bronchi and bronchioles. Through the central acinar arterioles, it goes into the pulmonary capillaries. I'm not going into very as anatomical detail of these things, but overall, from the main pulmonary artery, it is through the branching along with the bronchi and bronchioles into the central acinar arterioles, and from there it is divided into pulmonary capillaries. So this part of the circulation is carrying deoxygenated blood, and in the capillaries, pulmonary capillaries, it is oxygenated, and then it is coming as small peripheral acinar pulmonary veins with bronchi and bronchioles, and then four pulmonary veins to the left atrium. This is a rough idea of the functional anatomy, how it is. A little more what we need is that we need to understand that the pulmonary arteries, they are going very much parallel to with along with the bronchi and bronchial tree, whereas the pulmonary veins, they are remain within the septum, interlobular drainage. Pulmonary arteries, they are going along with the bronchovascular bundle, along with the bronchial tree. And pulmonary veins, that is not exactly. If we see here, this is a pulmonary artery, pulmonary phase, and you can see it's here it is also very parallel. Another artery, you can see here, this artery is the bronchial artery. We'll go in details. If we understand a little more, that arteries and air, that means the pulmonary arteries and the bronchial tree, they run together in the center of the lung segments, whereas the pulmonary veins run alone at the boundaries between the segments. A little more detail if we see, you can see the arteries are going like this, particularly when we are coming to the respiratory bronchiole, where to some extent gaseous exchange started, and as we go to the terminal alveoli, you see the arteries and the bronchial tree, they are going parallel, and veins, they are going separately. In addition, we have the bronchial artery, which is also running parallelly with bronchial tree. Pulmonary circulation, we have, so as we have learned, arises from the right ventricle via the pulmonary trunk, carrying deoxygenated blood. It feeds the vast alveolar capillary network for oxygen intake and carbon dioxide elimination. So gaseous exchange part is taken care at the alveolar capillary network. It accommodates the entire cardiac output from the right heart. Already we have discussed, nearly 5 liter per minute cardiac output is being accommodated within the short, wide, almost parallel capillaries of capillaries along with pulmonary arteries, pulmonary veins, not the bronchial arteries. It finally pulmonary circulation from the capillary, it goes through the pulmonary vein, empties into the left atrium via four highly distensible pulmonary veins. This is important, highly distensible. We will be discussing these things little bit later. Other side, see, this is for the gas exchange. This is the gas exchange, functional system of gas exchange. Whereas in bronchial circulation, bronchial arteries, we have the nutritive support, metabolic support to the bronchial tree. So this is very categorically clear that the pulmonary circulation is only for supporting the systemic circulation, only gaseous exchange. Apart from, there are some minor activities, like as already discussed, we have metabolic and emboli removal and some bradykinin, endothelin, those removal. Apart from these, the major function is the gas exchange. So it is a functional system. Whereas the bronchial circulation, these lungs and its structure, they need nutrition. They also need oxygen. Where from they will get? They will get from the nutritive system, the metabolic support from the bronchial circulation. So as we have seen, the lungs is receiving dual supply. One is through the pulmonary arteries, another is through the bronchial arteries. Pulmonary arteries are for gaseous exchange, whereas the bronchial arteries are for the nutritive support to the lungs structure. It arises from the systemic arterial network, branches of the thoracic aorta, and it supplies oxygenated blood to the conducting airways, pleura, and the connective tissues, carries only 1 to 2% of the total cardiac output, which is high pressure, low flow, drains partly into pulmonary veins. This is where we have important. The bronchial arteries we have mentioned, we didn't mention about the bronchial veins. So the blood partly into the pulmonary vein, forming a normal physiological shunt of venous admixture. Alveolar capillary network is the is another important structure. Apart from, so we have learned about the pulmonary artery and the pulmonary vein and the bronchial arteries, so dual circulation. This is purely pulmonary capillary network, which is for the gaseous exchange. What we can see here is the capillaries are highly dense. It is the bronchial pulmonary capillary network is highly dense capillary network along the alveolar structure. As you can see, almost single layer, single cell structures surrounding the alveolar structure, and it developed the alveolo-capillary membrane, where the basement membrane is fused and we have only few micron structure, so that gas can be easily exchanged between the alveolar air space and the plasma as well as RBC. Hemoglobin is here. So this is an ultrastructural gas barrier, easily exchanging gases, easily exchanging oxygen and carbon dioxide, with the peculiarities are minimal thickness. The barrier is only 0.2 to 0.6 micron, as I have mentioned already, enabling rapid passive gas diffusion. Sorry. The vast surface area here, as you can see, the surface area is so extensively covered. So total about 70 to 100 meters square in normal lung, optimizing high possible contact between the alveolar airspace and the plasma. Optimal transit time. RBCs spend only point can spend RBCs can spend 0.75 second in capillaries at rest, and during requirement it can be zero point 0.3 second, it can be as fast as 0.3 second. However, it is worthy noting here that 0.3 second time is sufficient for the RBCs to load its hemoglobin fully with 100% with oxygen. So the transit time is very perfectly matched as it is required. So if we compare the systemic circulation and the pulmonary circulation, as already we have mentioned that 5 liters of cardiac output for both pulmonary circulation as well as systemic circulation. So here it is equal. However, mean arterial pressure is only 15 millimeter mercury in pulmonary system, whereas it is 93 millimeter mercury in case of systemic circulation. So we have very extensively higher mean arterial pressure in systemic circulation and relatively very less mean arterial pressure in the pulmonary circulation. However, surprisingly, the venous blood pressure is not that much different. It can vary around 2 to 8 millimeter mercury, whereas it is around 2 to 20 millimeter mercury. Okay, we can consider it is quite not exactly matching, but there is a possibility it can match. Vascular resistance, pulmonary system, pulmonary circulation, vascular resistance is quite less compared to the 19 to 20 millimeter mercury per minute liter of, or 1500 dynes per centimeter square centimeter. This, so as you can see, vascular resistance is quite high in systemic circulation or quite less in pulmonary system. Vascular compliance, it is highly compliant. Pulmonary circulation is highly compliant compared to the systemic circulation. So this is the major difference comparison, hemodynamic comparison between the systemic circulation and pulmonary circulation. Cardiac output is equal, mean arterial pressure is less compared to systemic. Vascular venous blood pressure is almost maybe matching sometime, comparable we can say, comparable. Vascular resistance is very less and it is highly compliant system. If we think of the flow of blood through the pulmonary capillaries and the systemic pulmonary circulation as well as systemic circulation, as already I have mentioned, that it takes only 0.75 second at rest and 0.3 second during exercise. So the time required is matching as it is required it varies from 0.3 to 0.75. The mean velocity of blood in the pulmonary bed is almost the same as that of the aorta, then falls rapidly and then rises slightly again in the larger pulmonary veins. So if we compare pulmonary vessel, pulmonary arteries, pulmonary veins, and this is the pulmonary capillary. Lowest blood flow rate is very less at the capillary, because the same amount of blood is being distributed in high cross-sectional, large cross-sectional area, and then the arteries and veins are comparable, matching with each other. As already we have mentioned, the short pulmonary capillaries and carrying full cardiac output. This is the key, short and full cardiac output. So we have to keep in line the systemic circulation and pulmonary circulation. They are appearing that it is like running parallel to each other. But in fact, if you notice carefully, they are in the series connection. Both of these circulation, they are in the series connection. So whatever is coming out of the systemic circulation, that has to be taken by the system, by the pulmonary circulation. While the the path length of this pulmonary circulation, path length is too short compared to the whole body of the lung, of the body of the human lungs. It is only this small part of the body taking whole blood, equal blood supply, but only small part. Whereas the whole body is being distributed. So we need same volume, same rate of flow. The capacity is variable. As we know, during severe exercise, the cardiac output can be 5 times higher than the rest. If cardiac output is say 25 liters, this 25 liter of cardiac output is being distributed into a body as per requirement. However, the same amount has to be included within the systemic circulation. So the adjustability in adjustability in the pulmonary circulation is too much, so that it can accommodate, as it is being supplied, it has no specific changes, but it has to accommodate whatever the systemic circulation is giving it. Like if systemic circulation is giving it 5, it has to reach it 5. If it is 10, it has to increase 10. If it is 15, it has to increase 15. It has to, this way, whatever is given by the pulmonary, by the systemic circulation, pulmonary circulation has to adjust with it. This another important what we have already discussed. It provide a layer of blood around each alveolus so that the alveolo-capillary membrane can do the job within 0.3 second time. So this time flow, when the blood flow is increased up to 25 liter, we have only 0.3 second left. Within that 0.3 second, it has to get sufficient oxygen, as well as it release sufficient all the available carbon dioxide with it. So this part, to make this part possible, we have the alveoli are almost surrounded by a layer of blood. A layer of blood around each alveoli. What we have seen, if we see it something like here it was very much network, but by the time, if it think of in a physiological level, it's very small. It is almost a layer of blood, a sheet of blood, rather than individual tube. Just to explain the capillary density, I have shown it in a larger scale. But if you think of in our body structure, the pulmonary capillary network is so dense and interconnected that the blood flows as a sheet of blood. No space of the alveolar surface can be wasted. That's why we are making it available for for gaseous exchange, and it is something like a sheet of blood, a layer of blood over the alveolar surface. Coming back to the volume while can see that in clinical aspect also there is a parameter called percentage total cross sectional area from the pulmonary vessel less than 5 millimeter square, something like around 2.5 millimeter diameter is important for the vessel. It is clinically very important. It is utilized for the clinical evaluation. The volume of blood in the pulmonary vessel at any time, resting condition at any time when we are placed is around 1 liter. Out of 1 liter, only less than 100 ml of blood remain in pulmonary capillaries. Now, this is another important aspect. One side, we are saying there is large alveolar surface area. So, by we are providing sufficient gas, then we are providing a very thin pulmonary capillaries. Sorry, thin pulmonary capillaries, so that it appears like a very ultra thin layer of blood, almost single layer of cells, as we have seen. Single layer of cells are moving around the alveolar surface. This is possible because the large diameters of arteries and veins, they are accommodating almost 90% of the blood in the pulmonary circulation. As a result, only around 100 ml of blood is available for the gaseous exchange. So this ensures that within 0.3 second, roughly 100 ml of blood is being loaded sufficiently with oxygen. If we consider the pressure, already I have mentioned that roughly 15 millimeter of mercury pressure in the pulmonary system and around 95 millimeter mercury pressure in the systemic circulation. There is around sevenfold less mean pressure in the pulmonary circulation. But the importance is there is a tenfold less pressure gradient. If we consider the pressure gradient, this is tenfold less pressure gradient, and this less pressure gradient is confirmed that the blood is sufficiently flowing without causing excess pressure. Why we should bother about excess pressure? This is another important aspect. Think of if we have the excess hydrostatic pressure, what will happen? The thin layer of alveoli, they will be broken. There will be excess fluid accumulation. So, not only that, we have low pressure gradient, it is matching with our requirement and the instrument, the organ available with us, which is perfectly doing its job. The major pressure drop occurs through the pulmonary capillaries, whereas in systemic circulation, it happens in the resistance vessel, the arterioles, metarterioles particularly. As I have mentioned, the pulmonary arterial pressure need not be as high as the systemic arterial pressure, because there is no need to overcome the effects of gravity. For systemic circulation, heart is here, it has to overcome this. When we are in erect posture, it has to overcome this, and at the same time the blood need to back from the toes to the heart. So there are number of vascular beds within the systemic circulation, Whereas in pulmonary circulation, we have only one vascular bed. So the resistance is less, gravity load is less, so minimum pressure is required and sufficient enough to produce, to run the pulmonary circulation, and which is matching exactly the systemic circulation. This is a flow diagram where you can see we start with this thin wall of right ventricle. The thin wall of right ventricle as well as the below property of the ventricular contraction. The ventricular contraction, if you remember, the heart muscles, left ventricle contract like this, whereas the right ventricle is contracting like this below. While it is trying to create a pressure here, the left ventricle wall is also moving. So as an effect, we get only low pressure developed by the thin wall of right ventricle as well as its contractile mechanism. This low pressure keep the net filtration pressure at capillaries such a way that the alveoli kept dry for gaseous exchange. If the pressure would have been higher, we would have accumulated fluid here, pulmonary edema here. This low pressure is sufficient so that the capillaries can withstand. The capillaries, they have very poor supporting structure, single cell layer. It's almost the alveoli, they are the air-filled sacs. No support against the intravascular pressure as surrounded by the air-filled alveoli. So this, if the pressure would have been a little higher, there is a possibility that the capillary walls would have been ruptured. So this thin wall right ventricle and its mechanism of contraction, creating only low pressure, which is mean arterial pressure is around 15 millimeter mercury, and as we have noticed, the maximum pressure is 24 millimeter mercury. So this low pressure keeping the alveoli dry as well as is supporting the capillaries so that there is no rupture. Now, the thin walls of pulmonary vessels. These pulmonary vessels, they are also very thin walled, as already we have discussed that large pulmonary vessels, they are 30% less, only 30% thickness compared to the systemic circulation, as well as we have noticed that the smaller vessels, they have thinner vessel wall because of less muscles within the wall. This provide low resistance. Because of low resistance, the low pressure is sufficient to distribute the blood throughout the pulmonary circulation. This thin wall pulmonary vessels, it is highly compliant. Already we have seen that compliance, it is highly compliant because it is thin wall, and the highly distensible, it is highly distensible. As a result, it can act as a reservoir. When there is an increase in cardiac output in systemic circulation, it has to be matched by the pulmonary circulation, whereas we cannot increase the flow in the increase the amount of blood in the capillaries, so it has to be increased, the volume to be distended by the volume to be kept by the large pulmonary arteries as well as pulmonary veins. So this slide, this picture explains a very composite concept of functional, this structure of the thin wall right ventricle, how it works, low pressure this side, and the thin wall pulmonary vessels exactly supporting this whole system, and overall the pulmonary circulation. Because of this structure, the pulmonary circulation can support the systemic circulation. As we have mentioned, that it is highly compliant. The system has a remarkable ability to reduce the resistance and as the blood pressure rises. Mean arterial pressure, if it is rising, see, the resistance, pulmonary vascular resistance is decreasing, causing increase in pulmonary blood flow. So, because of this, because it is thin walled, it has lower thickness, thin walled and lower content of smooth muscles on the vessels. The pulmonary circulation is highly compliant. Along with this, there is other two mechanisms. One is recruitment, opening of previously closed non-perfused capillary. As you can see, these were non-perfused. This is a very representative diagram, as you know, it is very much representative only, just to show that these are non-perfused capillaries. These are now being perfused. So, opening of previously closed non-perfused capillaries when blood flow increases. This is called recruitment. And there is widening of blood of vessels which are already in flow. So, two mechanisms, recruitment and distension. These two mechanisms, they drastically decrease the pulmonary vascular resistance, or other way around, it causes the pulmonary circulation highly compliant. And many a time these two mechanisms are working together. So the recruitment and distension, these two are two mechanisms, so that the pulmonary vascular resistance is reduced and it can be utilized for the adjustment up, as required during exercise or during demand. Already we have mentioned that it is low resistance. Because of their distensibility, the pulmonary veins are important reservoir. When a normal individual lies down, the pulmonary blood volume increases up to 400 milliliter. And when the person stands up, the blood is discharged into the general circulation. This causes decrease in vital capacity in the supine position. Sometimes we ask these questions with the spirometry, during spirometry, that vital capacity, why it is decreased in supine position, or it is the cause for the orthopnea in heart failure. In erect posture, this type of alveolar arrangement, we can imagine it is not exactly the same way, as I have already mentioned. It is not exactly the same way, but we can imagine that the apical part, alveoli are distended, and the base here, the alveoli are congested, smaller. So at apex, intrapulmonary pressure is more negative, transmural pressure is greater, alveoli are larger, intravascular pressure is lower, blood flow is less, perfusion and ventilation are less. This is the regional variation which is shown in the lungs when it is in upright posture, upright position, upright standing, erect posture, because there is no supporting structure. This part, if you know, if you remember, there is pleura. So within two pleural fluid, it is hanging. Only structural support is this part. So here, these alveoli, the apical alveoli, they face high intrapulmonary pressure, negative high negative. As a result, the alveoli are larger. Because of this, there is less blood flow and perfusion as well as ventilation are less. Accordingly, there are three specific zones have been identified where, as you can see here, the alveoli they are enlarged. Here it is not matching exactly, it is little larger, it should be little alveoli should be little smaller. Here you can see the alveoli pressure is very much greater. PA, the alveolar pressure is very much greater than the arterial pressure as well as venous pressure. This part is called zone 1, where the pulmonary blood flow is very less, very less. In zone 2, the arterial pressure is greater than the alveolar pressure, which is greater than the venous pressure. So, as a result, this part of the lungs is receiving supply when there is high pressure, high arterial pressure during systole. During systole, high arterial pressure. As a result, the blood flows through this zone during the systole, but not necessarily during the diastole. Whereas in zone 3, the blood flow is continuous irrespective of the arterial pressure or irrespective of the systole or diastole, because the alveolar pressure is very much less. If you compare it with the this structure, here the alveolar pressures are less, here alveolar pressure is high. So the zones are divided accordingly: zone 1, zone 2, zone 3. Mostly it is not really true that this part of the zone 1 of the lung is not receiving blood flow at all. It is only representative, very much representative. Here it is very low, very less, and here during maximum during systolic and minimum during diastolic, where here also there is systolic diastolic variation, but during diastole also there are continuous supply to some extent. In addition to this, there is zone 4 is also considered for the which is very much the lowest possible part of the lung, where the interstitial pressure comes in handy and there is minimum supply. So zone 3, out in case we consider 4 zones, these zone 4 is also important, which is important for our for the anesthesia operating time. For them it is more important. We consider zone up to this stage. Physiologically zone 2 and zone 3 are important. Zone 4 is clinically important for the anesthesia. Now coming to the condition, as already I have mentioned that the high pressure at the apex and the base, there is a zone difference. These zone differences causes the alveoli movement. So gaseous exchange will be maximum here at the base, whereas minimum here. Even though it is maximally expanded, the movement of ventilation is relatively less at the apex and very much considerably higher in base. This, when we consider in case of capillary fluid, capillary flow, you can notice here that the apical alveoli, they are continuously blocking the part of the capillaries so that the blood flow is being hindered. Whereas because there is greater movement of the basal alveoli, the capillaries have at least one point of time during respiration, during one respiratory cycle, where it can have a full blown circulation, whereas in apical part it is always a restricted circulation. In this context, we need to understand the ventilation perfusion ratio, but we are not going into that. This is also a very important point, very important aspect. As you can notice that the at the apical part, the both blood flow as well as ventilation both are less, but the ventilation perfusion ratio, it is very much high here at the apical part. So this is we need more time for that. We are not included that part here. Ventilation perfusion ratio is also another important, and you can read on your own. Then if we think of the alveolar vessels, the to understand the zone 4 effect, if we particularly the zone 4 effect, extraalveolar blood vessels, they are highly expanded during negative pressure, but because of this high larger alveolar structure, it is blocking the alveolar blood vessels. So alveolar blood vessels are being blocked by the enlargement, by the opening of enlargement of the alveoli at the base. This causes, so the alveolar vessels, they are compressed at high lung volume as alveoli expand at stages, increasing vascular resistance. Whereas the extravalvular vessels pulled open at high lung volumes via radial traction from the surrounding elastic tissue, lung tissues. If we plot it in a graphical way, we see that the during functional, with the functional residual capacity, what is very important, the functional residual capacity, as you can see here, the lung pulmonary vascular resistance is lowest. High lung volume, it is increased. Low lung volume, it is increased. But at the FRC, it is the lowest. This is very important for understanding that capillary dynamics. I'm not going into detail because it is not so important at the undergraduate level, and for clinical it is very important. So minimum total pulmonary vascular resistance is achieved at functional residual capacity, what is the end normal end expiratory, at the eugenic state of end expiratory condition. Alveolar fluid balance, we have, because of already we have discussed that the low pressure and low resistance structure is helping us to keep the alveolar spaces dry, so that we can have proper gaseous exchange, sufficient gaseous exchange, and in case if it is disturbed, then we will be facing the pulmonary edema. So roughly we have a safety margin of around 21 millimeter mercury. The key regulators of pulmonary circulation, obviously the systemic circulation, whatever it gives, it has to the pulmonary circulation has to take that. So cardiac output or the systemic circulation is the key regulator. Respiratory cycle is also important one, so that the sufficient time can be provided. Gravity during respiration and during erect posture and the lying posture, there is difference. And as you know, during COVID we had that particular posture of gas ventilation that is to be helpful. Then there are reflex control by the baroreceptor stimulation as well as chemoreceptor stimulation. These also regulates the pulmonary circulation. And very importantly, the hypoxia. Hypoxia causes pulmonary circulation. There is vasoconstriction of the pulmonary circulation, so that the blood can be redirected to the highly ventilated areas for proper gaseous exchange or hemoglobin saturation with oxygen and removal of carbon dioxide. So this is a very important one. We will explain this at later stage. Then pulmonary circulation, other regulations, obviously the uh, neural control is there, and the cardiac output of we have discussed. Vasoactive and local influences like thromboxane A2, prostacyclin, nitric oxide, endothelin, serotonin, these are also important. And there is autoregulation, local autoregulation. This is another important before we conclude. The most systemic tissues we get where autoregulatory mechanism is something like with low oxygen levels, vasodilation should be said there, so that oxygen supply can be there. With high oxygen level, vasoconstriction. But it is opposite in case of pulmonary tissues, where vasoconstriction is seen with low oxygen level, and high oxygen level causes vasodilatation, so that the proper gaseous exchange can be given. The mechanism for this is potassium ion channels. So those who are interested, they can read more of it. It is really a nice point to discuss. Then clinical importance or applied part. Normally it is not pulmonary pressure is should not be high, but if the pulmonary arterial pressure is increased more than 20 millimeter mercury at rest, then it is called pulmonary hypertension, and it leads to progressive increase in right ventricular afterload, resulting in right heart failure, or pulmonary sometimes it is called. Pulmonary edema occurs when capillary filtration exceeds the lymphatic drainage. Highly capillary hydrostatic pressure can lead to as fluid accumulation, as in case of mitral stenosis, left ventricular failure. Pulmonary embolism, acute occlusion of the pulmonary arterial branches, usually by deep vein thrombus. As I have mentioned in the beginning itself, the filtering the emboli, but that can lead to a bigger problem in case of pulmonary embolism, which will increase the dead space and right-sided strain. In lungs, we have very highly extensive lymphatic system. I'm not going into detail of this. So to sum up, we have discussed about the pulmonary blood supply, pulmonary blood vessels, pressure, volume and flow, pulmonary reservoir, zones, pulmonary capillary dynamics, and the pulmonary regulation of pulmonary circulation. Uh, Maybe a question: why is hypoxic vasoconstriction unique to the pulmonary circuit, and what are the its systemic differences? Already we have discussed. I think anyone can answer. This is a protective mechanism, so that the ventilation perfusion ratio is matched always. When which part of the lungs is well ventilated, that should receive maximum perfusion. This is the mechanism. How does the pulmonary circulation accommodate a massive increase in cardiac output during vigorous exercise without a corresponding pressure spike? Pressure bar is not increased, but still we can accommodate the same because of this distension as well as recruitment. I hope you may have many more questions. Anyway, I don't see any questions here. Thank you very much for your attention. If you have any queries, you can connect me or the society, so that it can be we can discuss those points. Thank you. Thank you, everyone. I'm ending the session. Thank you.